Hi, ladies and gentlemen. Welcome to this edition of the Cameroon Town Hall for Healthcare Professionals. This is a platform that brings together healthcare professionals from Cameroon who are spread all around the globe. So far, we have about 1,200 registered participants on this platform from about 34 countries. So our number is increasing every day, and our objective is to meet here every fortnight to have a conversation on interesting topics on healthcare that affects the people back home, and to share our knowledge with our folks back home, and also see how we can contribute in improving on the healthcare situation of our people. Last week, we had a very interesting conversation with Dr. Kennedy Foyon, who is one of the experts that brought us a very interesting talk on improving access to sustainable diagnostic radiology in a resource-limited setting. We want to thank you once again, Dr. Kennedy, for your time and for that very interesting conversation that we had. Today, we are going to be having a very interesting talk. And before then, let me introduce my co-moderators. I will be handling this session today with Dr. Louisa Viban, who is a resident physician in Canada. Louisa, hello.
Hi, Elvis. Good afternoon, good morning, good evening to everyone. Thank you all always for creating this time to log into the town hall. We do appreciate every effort, everyone who comes in every time, all the presenters who always make out time out of their busy schedules to come and share the knowledge with us. It's really important that we all come here once in a while to work towards our common goal, which is patient safety, and make sure that our health keeps growing for the better. Thank you, everyone, and we really look forward to this session. And Elvis, it's always a great pleasure co-moderating the sessions with you. Thank you.
I'm so happy to see you. We've missed you for some sessions, and when I saw you today, I was like, yay, she's here. So thank you for taking time out of your busy schedule. I know you're on call today, but we are really glad to have you. We shall also be having Dr. Brian Tegomo, who is also one of the co-moderators, and of course, our own Dr. Alison Weyer. So we look forward to, I don't know if, Brian, are you already in? I think Brian is still to join us, and I'm sure Alison too is still to join us. So, of course, we want to welcome our own chair, Dr. Muno Ken, for always doing this amazing work backstage to ensure that we have these sessions every fortnight, working very hard to identify our speakers and to make sure that we get the best of experts to come talk to us. Muno, hello.
Yeah, Elvis, I want to always thank you guys for the wonderful job you've been doing, and for keeping this Cameroon Town Hall for Healthcare Professionals very sustainable. And really, it's been a good ride. And I think we're going to actually change the healthcare system in Cameroon by talking about these problems and motivating people who are in our platform to actually look for solutions. And we may look for solutions ourselves. And I just want to also thank one of your co-moderators, Christelle. She's here. I think you didn't see her. I saw her commenting also in the, she's one of those who has been making sure that we stay bilingual and we get to reach out to all the different groups which are available in Cameroon. So thank you. And without getting into the topic of today, I just want to thank Dr. Yauba, which you're going to introduce. And his presence here is very, very important. We're going to talk about a very important topic that I hold very dear to my heart, and that is access to oxygen. So it's a wonderful thing to talk about this, because during the peak of the second pandemic in Cameroon, we got to practically deal with a problem like this. I had to call in several times with WHO, with Dr. Brunhilde, in order to really see that this is a big problem. And I'm happy that the Clinton Foundation has been trying to help in this regard. So Elvis, I'm gonna hand over to you and the other co-moderators. Thank you very much. And thanks for being faithful with the rest of the co-moderators. And thanks to everyone who is here today. This town hall belongs to you all. So thank you.
Thank you so much, Chair. And I really want to say we really appreciate your leadership in steering this very wonderful initiative up to this moment. And we're only growing from strength to strength, thanks to the amazing work you are doing backstage. And let me check on with some of our regulars who are on again. Kenji, Dr. Kenji, hello. Kenji, maybe he is, and George Lehman. George, you moved from Maryland to Texas. George, how are you today? Right, I'm checking on some of our regulars. And Emmanuel Folag, hello.
Good evening, everyone. It's a pleasure
to
be here today.
It's really a great pleasure. Et Christelle, une fois bonjour et comment vous pensez de cette discours d'aujourd'hui?
Bonsoir Elvis, bonsoir à tout le monde et bienvenue à chacun à cette nouvelle édition de Cameroon Town Hall. Je pense que cette édition sera très édifiante parce qu'elle soulève un sujet d'actualité et qui nous concerne tous. Bienvenue à chacun et merci à toute l'équipe dirigeante, Dr. Foma, Louisa et toi aussi Elvis. Bienvenue à chacun.
Merci beaucoup, Christelle, et je pense qu'on va bien aimer cette édition. Merci beaucoup de votre présence. So once again, it's really a great pleasure, and we are going to dive right away to discover our presenter, who is Dr. Yauba Seydou. Yauba, please, can you put on your camera while I introduce you to the audience? I know you're going to switch it off later on, but if you can just turn on your camera. Thank you very much. Here is Dr. Yauba Seydou, whom we are going to be listening to today. And I have the pleasure to introduce Yauba. Yauba is, first of all, my big in school. When we were all in secondary school together, and I used to carry his plate to the refectory for those who have been in the dormitory. So Yauba is my big, and he'll continuously be my big forever. Always my big. Thank you so much. I'm so proud to introduce you. Dr. Yauba Seydou obtained his medical degree from the University of Yaoundé in 2007. And after practicing for 2 years in Cameroon, he proceeded to pursue a master's in vaccinology and drug development at the University of Siena in Italy. Thereafter, he worked for a year as a clinical research associate at Novartis Vaccine and Diagnostics before heading to Gambia, where he successfully coordinated the planning and conduct of 4 large-scale industry-sponsored vaccine trials. After 4 years in Gambia, he joined the Clinton Health Access Initiative and returned to Cameroon. And in Cameroon, he successfully established a vaccine program which supported the government to dramatically transform its vaccine cold chain system, moving from 3% sufficiency in 2015 when he started to about 78% now. Aside from vaccine, he has successfully set up a cancer program, a non-communicable disease program, and also an injury program, alongside a family planning program. And more recently, he has 2 ongoing programs to support the government in its COVID-19 response strategy, including diagnostic and essential medicine program, and access, of course, to medical oxygen. Yauba is currently the acting country director for the Clinton Health Access Initiative in Cameroon. He's also a medical advisor at the Institute for Global Health at the University of Siena, Italy, as well as a content editor for Global Health Process. He is also a member of the Cameroon's National Immunization Technical Advisory Group and is a principal investigator for an ongoing Bill and Melinda Gates Foundation policy analysis study in West Africa. He has co-authored over 30 publications and is currently supervising 3 master's degree students. So this is Dr. Yauba. We are so glad to have you today. We know when it comes to vaccines, and also you are a trusted authority, but today you shall be telling us on something you are very passionate about, which is access to medical oxygen. And I understand you've done really great work with the government of Cameroon to improve on the cold chain, but also recently to see how to help the government, improve access to vaccine, especially COVID vaccine in Cameroon. So I want to thank you for the enormous work you are doing to transform the healthcare sector in Cameroon. And we are so glad to have you today. So welcome, Dr. Yauba. You can take it away from me.
Thank you very much, Elvis. I myself, I was looking forward to meet the person you are introducing. And secondly, there is another important part you did mention when you took my plate to the refectory. I think during the week that you took my plate to the refectory, I ended up eating food without meat. So you need perhaps to explain at one point in time where my meat went to. Okay, thank you, Elvis, for that introduction, and it's actually a pleasure to be here. It's also a pleasure to see some colleagues online, particularly Charles Kweche Pechu, Fadimatu Altine, and Tambasho. I think these are people I've not seen for quite some time, so it's kind of good to see that a platform like this can actually bring people. It can actually bring people together, including those we haven't seen for quite some time. So I think for the benefit of the streaming, I would like to switch off my video. You know, we are in Cameroon, and certainly the streaming might not be good if I try to share my screen while on video. So with their permission, I can proceed to shut down my video. And then now I will attempt to share my screen, and please let me know whether you are seeing my screen.
Yes.
Okay, great. So you can see that I have just 21 slides. I'm not the master in this subject, so I just try to learn what I have learned, what I know so far within the past 2-3 months. So I have titled this talk access to medical oxygen in Cameroon, a call to action, because I think it's based on what I have seen, how patients are suffering, COVID patients are grasping for oxygen, families are in disarray. I think there is really a moral duty for some of us physicians and also the broader community to start thinking about what we can do to improve access to medical oxygen in Cameroon. So I have this presentation, 21 slides, with this agenda, which consists of 3 points and about, I think about 1, 2, 3, maybe about 10 sub-points. So first of all, I would want to walk you through an introduction where I will briefly touch on hypoxia, COVID-19 surge in Cameroon, and then a little bit of overview about COVID consumption, not in Cameroon, but across from the literature. Then I will talk about the methodology for developing the national strategy that we just got validated by His Excellency, the Minister of Health. And before validating the strategy, we had to do a number of things, including conducting the situational analysis, which I will be happy to share the findings in this platform. Then I want to walk you through, just provide you a high-level overview of the national strategy, its vision and objective, key interventions, the budget, and perhaps key achievements and next steps. So I do not have slides on key achievements and next steps, but I think I can voice over when I show the funding picture for this strategy. So in terms of introduction, I think you clinicians, you should know this better than me, that hypoxia is a potentially fatal condition which results from abnormal low blood oxygen levels. It can quickly lead to multiple organ dysfunctions, and it can occur in conditions such as pneumonia, preterm, surgery, sepsis, HIV, malaria, and so on and so forth. So I think the last time I was talking to some emergency physicians, they did indicate to me, can you hear me?
Yes, we can hear you.
Okay, great. So the last time I was talking to emergency medicine physicians, they did indicate to me that most deaths in hospital result from 2 sources. One is either hypoxia or lack of respiratory failure, and the second is cardiac failure. So which actually means that before a patient will progress to death, then the patient might experience hypoxia or hypoxemia. We all know, at least from the literature, that hypoxia or hypoxemia is a very common condition. You can the table on the right kind of shows the percentage of people with hypoxemia that have been reported in the literature. Patients suffering from pneumonia, diarrhea, malaria, meningitis, and even preterm births. So the table on the right actually shows that no matter the primary diagnosis, if there is a hypoxemia, then the odds of that person dying increases by up to 7 times. So this is really a serious condition. So moving to the next slide, here I just want to show the number of COVID cases that we have had up to 25th of August when we prepared this slide. I actually borrowed it from the Director of Corporations. So you all know Cameroon, the burden of COVID-19 in Cameroon has been relatively mild compared to other countries in the world and Africa. But irrespective of the mild nature, COVID-19 has actually helped to kind of unveil the gaps that we have when it comes to the gaps that we have in our oxygen infrastructure. So I think currently we are only able to meet about 25 to 35% of the needs, and as the country is moving towards a third wave, there are a lot of concerns. Me in particular, I'm really much concerned about what might happen if patients tend to require more oxygen. So here we know that COVID-19 is associated with case management of COVID-19, particularly for critical patients, require a lot of oxygen. And according to WHO, patients are supposed to receive about 30 liters per minute for 14 days, and that translates to about slightly over 600,000 liters for 14 days. And if you want to convert that into bottles on the right, that may be well above a million bottles, 50 liters bottle. And you all know access to medical oxygen, be it the cylinders themselves or the molecule itself, is a challenge across the developing world. In the context of Cameroon, I think when we did the assessment, we found that we had just slightly less than 500 cylinders in the entire nation, which is really concerning. And when you talk about the molecule itself, we have very limited providers that supply the molecule to health facilities. And most often this molecule will need to be imported from France, from Cote d'Ivoire, or from Gabon, with a lead time of about 3 weeks, which is really a concern. So faced with the probability of entering into a third wave, His Excellency the Minister of Public Health, Dr. Manauda Malachi, established a task force on the 11th of May. So I happen to be a member of the task force, and the task force actually had 3 specific objectives. One was to conduct a situational analysis. Two is actually to leverage findings from the situational analysis to develop a 5-year strategy, at least providing orientations that the country should take to sustainably address the oxygen problem in Cameroon. And then the third objective is actually to support the country to mobilize resources to fund the strategy. So coming back to the roadmap, the task force was established in May. Once the task force was established, we rapidly prepared assessment protocols and tools, which enabled us to collect data from roughly 130 facilities. And once we got the data, we analyzed the data, we identified key bottlenecks, and then we leverage these key bottlenecks to establish a 5-year strategy. So in the course of developing the strategy, we also had to support with resource mobilization. Within Chad, we did mobilize about $1 million, and we also supported the government to mobilize roughly $25 million from the Global Fund. And I know UNICEF is also engaged in mobilizing resources. They have also supported the government with some equipments, but they are currently in the phase of mobilizing resources to support the implementation of the strategy. So the situational analysis actually helped us to understand different challenges, or to have first-hand information about the state of oxygen equipment and case management of patients with hypoxia at health facility. So I have mentioned the objectives of the assessment, and as well as the methodology. So perhaps I will skip this slide. So in terms of of the first objective, which was kind of designed to enable us understand the policy framework, the policy and legislative framework that governs the use of medical oxygen in health facility, we kind of realized that there is no policy governing clinical use of medical oxygen in Cameroon. And in addition, there are no norms and standards to regulate the importation and distribution of medical oxygen commodities. As a result, the sector remains poorly regulated, which is really a problem. In terms of financing, there is currently no budget line for medical oxygen at national level. There is no directive for financing medical oxygen at facilities, and what's still there are no guidelines for pricing medical oxygen at facilities. So most of you who have worked in Cameroon, you will bear testimony that patients actually have to bear a large burden when trying to get treated with medical oxygen, and this can range from 5,000 to 10,000 and even up to 30,000, depending on where in the hospital you find yourself. So we estimated an average of about 18 US dollars for 24 hours, which is really high for a normal Cameroonian. For a normal Cameroonian, we also need to recall that about 34-35% of Cameroonians live below the international poverty line. So many of them cannot afford medical oxygen. So in terms of availability, what we know is that the Cameroon healthcare system has a pyramidal structure, as we are often told. And what we did is that we kind of limited, I don't know whether you can see my mouse, we kind of limited our sample to these facilities at district level, because field experience actually informed us that we don't have equipment to diagnose hypoxia in facilities beyond the district level. So there are also no equipment to manage medical oxygen at the time of the assessment, and that is why we excluded this in our analysis. So the analysis, the findings that I'm going to present will actually represent data collected from the seven COVID specialized COVID treatment centers, 6 general hospitals, 9 central hospitals, all 15 regional hospitals, and a cross section of district hospitals, both private and public. I think we collected data from about 87 district hospitals. So what did we find? At reference hospitals, sadly, if you go to the hospitals, you realize that you are likely to see that 85% of reference hospitals, and these are big hospitals like the regional hospitals themselves, the CHU, the general hospitals, up to about 85% have access to at least one source of medical oxygen. This can be oxygen supplied through a concentrator, which we know is not ideal for COVID patients, through oxygen cylinders, or through oxygen concentrators. But the percentage actually dropped to at district level. And on the right, you will see a somehow concerning diagram, which kinds of depicts at least the distribution of health facilities with medical oxygen across the country. So the black dots that you see are actually settlements or populations. The blue dots are actually health facilities, and then the red cross or the red X actually denotes that this facility has medical oxygen. So if you are sick and you go to this facility, if you are sick and you need oxygen and you go to this facility, then you are at least sure of getting oxygen from at least one source, either an oxygen plant, a concentrator, or a bottle or a cylinder. But what we tend to see is that majority of the population kinds of reside beyond the reach of facilities with medical oxygen. So to us, this is really a call for concern and also a call for action, because we kind of viewed this as a moral obligation to kind of look at ways of expanding access to oxygen. And believe me, in a region like Adamawa and also the center and perhaps the northwest and extreme north, distances are really, really great. So if a patient is suffering from hypoxemia from hypoxemia and needs oxygen, by the time that patient gets to the facility that has oxygen, I really wonder the state that the patient will get to that facility. So it's really an eye-opener for us, and it's really a call for action. So we think there is a need to actually invest in medical oxygen, as well as expand access to medical oxygen in Cameroon. So moving to the next slide, when we looked at the distribution of medical oxygen across the different services in each of the hospitals, we tend to realize that basically not all intensive care units have oxygen, at least a source of medical oxygen. Emergency units the same, operating rooms the same, and so on. And the situation appears to be worse in district hospitals compared to reference hospitals like the regional hospitals and general hospitals. Again, when we look at the different materials and commodities that are necessary to provide medical oxygen to patients, we also see significant gaps, particularly at district level, when less than 50% of surveyed districts have these materials, which is also a big concern for us. Again, when we look at the different sources, I mentioned cylinders, concentrators, and oxygen plants. We tend to see that we tend to see some sort of diversity at regional and also at district level. So it's common to go to a hospital and see a concentrator, and also see oxygen in cylinder, but the percentages are really, really low, particularly at district level. So oxygen plant, just about 11% of hospitals have oxygen plant, and in terms of numbers, it's actually 3. So it's actually 3, and worse still, most of the oxygen plants that are available, they are not functioning. They are not functioning, which also is a concern. So when we look at other basic commodities like pulse oximeters, which are necessary to diagnose oxygen, and other things which are necessary to diagnose hypoxemia, and other equipments like the chest X-ray or multi-parameter monitor, and also access to blood gas, we tend to see extremely low percentages at district level, and at reference hospital is kind of acceptable, but we can do more. So moving forward, in terms of data system, just about 15% of facilities reported documenting data related to the management of hypoxemia, which indicates that there is like an 85% gaps. But however, in facilities that are are collecting data on hypoxemia, they do not use standardized. They do not do that in the standardized manner, and as such, it's quite difficult to transmit this data and also to use it for decision making, and worse still, to incorporate it into the national system for health data management. So now, when we assemble all of this, the policy, the findings from the policy pillar, the equipment pillar, data systems, and so on, we kind of synthesize that and then produce some sort of themes that we could act on, that we could use to develop our strategy. And what were the themes that emerged? Essentially 4 themes: lack of policies and guidelines on the use of medical oxygen, lack of adequate and sustainable financing for medical oxygen, inadequate availability of oxygen equipment, materials and consumables for diagnosis and management of hypoxemia, and also lack of or inadequate systems for collecting and transmitting data on hypoxemia. So what did we do with the findings from this situational analysis? We actually leveraged it to develop a 5-year strategic plan, highlighting the core actions that Cameroon should take to transform its oxygen ecosystem. And this strategic plan was actually endorsed by the minister, by the Minister of Public Health, in a meeting that was presided by His Excellency the Minister on the 22nd of September 2022. I think just about 2 or 3 weeks ago. So now let me just walk you through the different components of the strategy. One, its vision, which is to ensure that we do not have hypoxemia-related deaths in health facilities in Cameroon, which of course is a noble vision, difficult to achieve, but is achievable. And then the strategic goal is to ensure that by 2025, at least 30 reduce hypoxia-related deaths by 30% by equipping all facilities with adequate and appropriate equipment and material for the diagnosis and management of hypoxia. That is also a very ambitious goal, but I think is achievable. So we kind of align our strategic objectives to the strategic pillars of the healthcare system, and the strategy itself has 4 objectives. The first one is to improve policy, governance, and financing frameworks for medical oxygen in Cameroon. The second is to improve availability of medical oxygen equipment and commodities in health facilities. The third is to improve case management of patients suffering from hypoxemia, essentially through the development of clinical guidelines and trainings. And the fourth is to improve data management systems for hypoxemia. So we do have a theory of change, and this slide is very busy. But we think that if we act on the inputs that we have defined, we are definitely going to have the output. So the inputs are essentially hovers around harnessing funds from Global Fund, UNICEF, UNITAID, GIZ, CDC, UNDP, WHO, to implement the interventions that we have defined in the strategy, which essentially includes things like construction of oxygen plants, acquisition and distribution of concentrators and cylinders, as well as oxygen commodities, trainings, and also putting in place data management systems. On all this under the coordination of MOH and its partners. So if we focus on these inputs, we definitely will get the outputs that we intend that we have outlined, which will essentially lead to the outcome and the impact. So one of the things that I wanted to show here is the decision-making framework that guided us on the decision on where we should put an oxygen plant, or the type of primary oxygen source that should be provided for each facility. And this is a question that we are asked from time to time. And this is a decision tree that actually enabled us to support the government to identify that they will need about 11 oxygen plants across the nation, small size, as well as 3 large size oxygen plants that are capable of producing oxygen, medical oxygen, and disseminating to peripheral health facilities. So if power is available and repair and maintenance can be guaranteed for big hospitals that have greater than 150 beds, we have recommended the use of the installation of PSA plants. So we currently, the MOH has currently acquired about 11 PSA plants, the 30 normal meter cubes, which should be coming in country and which should be deployed to 9 regional hospitals and 2 hospitals in Yaoundé. But we think that is also not enough. There must be some sort of backup, because these are equipment, they can fail. So where there is a primary source, that is a plant, we have recommended the use of secondary sources. This can be bottled oxygen or oxygen concentrators. We have also made provisions for the acquisition and installation of the liquid storage tanks in all the, I think about seven newly constructed regional reference centers, which we can, which are currently being finalized, which are currently being completed across the different regions. But where a facility is small, there is just no need in investing in PSA plan, because the OPEX or operational expenses for running a PSA plan will really outstrip the capacity of the hospital to finance. And that is why we recommended the use of oxygen concentrators, bedside concentrators, or oxygen cylinders, depending on whether there is electricity or no electricity. And so in terms of strategic investment, because of the distance and the need to ensure equity, we have previewed the installation of oxygen plants in the northern province and in the extreme north, and also Adamawa. I didn't put it here. And then we have previewed some sort of a hook and spoke kind of distribution in regions where we can easily acquire liquid oxygen. So moving forward, we have the budget, which it was in CFA. So I managed to translate that into, I managed to transform that into USD. So we are looking at a budget of about 228 million US dollars, which is quite substantial, about 114 billion francs CFA. So when you look at the budget itself, I think almost over 94% of the budget will essentially be invested in Objective 2, and this actually involves acquisition, buying, importing, deploying, commissioning, installing and commissioning of medical equipment. It will also include acquisition and deployment of oxygen commodities like masks and so on and so forth. So the budget is quite huge, and we are currently making efforts to mobilize funds, which you could see from this slide. So already, the state has mobilized about $4 million US from the Central African Development Bank, and these $4 million US have been used to acquire. Sorry, this is supposed to be 11 oxygen plants, which will be used to 11 oxygen plants, which will be deployed to 9 regional hospitals and 2 hospitals in Yaoundé. The state has also mobilized some funds from the Islamic Development Bank, and these funds were used to acquire 10,000 cylinders. And we recently submitted an application to Global Fund, so we need to update this number 20 million. So the proposal we submitted to Global Fund was actually valued at 25 million US dollars, and we got preliminary notification that these funds have been approved. So in the proposal, we previewed the procurement of 3 large oxygen plants, which will be installed in I think in the north, in the center region, and so on. And then we'll have some sort of a filling station, which will leverage to establish some sort of a spoke hub and spoke distribution system to peripheral facilities. So at Clinton Health Access Initiative, we did mobilize 500,000 US dollars to support everything related to strategy, and also everything related to strategy, and also things like trainings and so on. And we are working hard to mobilize additional 10 million US dollars. UNICEF itself has already invested 200,000 US dollars and is in the process of mobilizing 2 million US dollars. So currently the plan is funded at 2.2%, which is a good thing. I think this is the first plan. This is the first plan that I've seen that has some funding before it's approved, and that efforts have been engaged to mobilize additional funding. And it's also an opportunity for me to solicit the help of the diaspora to help in mobilizing funding so we could implement this plan. So I think with this, I come to the end of my presentation, and perhaps the moderator will open the floor for questions.
Wow. Thank you very much, Dr. Yauba, for this wonderful presentation. It's really been a great presentation. I spent a lot of time trying to capture all the details. Christelle, any comment?
Elvis, je dirais merci beaucoup à Dr. Yauba pour ce résumé très synthétique et très intéressant, très innovateur pour le pays et pour la distribution d'oxygène à travers le pays. Mes questions, vraiment, j'ai pas de questions, j'ai pris des notes, j'ai appris parce que ça avec beaucoup de données, mais j'invite chaque participant à poser des questions, soit en levant la main ou en écrivant dans le chat que nous puissions faire parvenir à Dr. Yauba. Merci.
Thank you so much. And Dr. Yauba, if you don't mind, you can stop sharing your screen so we see the faces of all those who will be asking questions. And thank you so much. And Louisa, your comments.
All right. I probably forgot to mention earlier that this is Thanksgiving weekend in Canada. So I just wanted to use this opportunity to say thank you again to everyone. And thank you so much, Dr. Yauba, for their presentation. It's really a great initiative. I really appreciate everything that you guys are doing. I don't know if it's a question or a comment, or it's just probably me trying to figure out how things are going to work out. But this is really a great initiative, coming up with a task force, having a goal in mind, trying to decrease mortality related to hypoxemia. But again, from a clinical standpoint, managing hypoxemia it's a whole lot. It encompasses different aspects of healthcare, from having the oxygen machines to being from being able to detect that a patient has need for oxygen, being able to determine how much oxygen the patient needs, looking at the biochemical changes that are occurring in the person. So all the labs that need to be done to see if there is, how the pH is going, having the oxygen machine, the oxygen source in our hospitals, and even when they do fellows, having people who are going to repair, to do all those works. So again, it's a lot of cost. It's going to be timely, but it's a great initiative. So my question is going to be more like, when I look at the budget that you presented, it really goes towards the goal. But after acquiring all of this, is there a plan to include, like, maybe recruit people who are going to make sure that once this fails, or there's someone who's going to repair on site? And also, you already mentioned that there's going to be like education and coming up with case management in hospitals, but just wanted to know what your plan is going forward with getting everybody mobilized and making sure that you prioritize areas where people always go to seek help. So most of the times our patients are not in the big hospitals, right? Like we have people go to primary healthcare and to regional hospitals in all parts of Cameroon. So what's the plan going forward? Thank you so much.
Great. Thanks so much, Lisa, and I'm sure Yauba got that question, and he's going to start with your question when he's given the chance to respond. And I'm just still taking around with all the co-moderators. Brian is here.
Thanks a lot. It's really great to be back. I really appreciate it. Just listen in on the last part of the talk, Dr. Yauba. Thanks a lot. Really been looking forward to your to this talk. Thanks so much for all the work that you do for non-communicable disease in Cameroon and oxygen provisions and everything that you've done over the years. Really appreciate all your work, and really appreciate all your work. Thanks a lot. I have no question, Elvis. Thanks a lot. Really great to be back.
Thank you, Brian. We are so happy to have you today again. We'll get to our chair, Dr. Muno, comments before we turn over to the hall for questions.
Yeah, it's been a very eye-opening presentation, and it shows to me that once you have people who understand the country where they're working, those who are actually involved in non-governmental organizations who are from the country, they get to see the problem that we're facing, they understand it better, and they can propose solutions. And Luisa asked a lot of very pertinent questions, which I know Dr. Yauba knows Cameroon very well. The issue of getting these plans, getting power, and he mentioned it in his presentation, which is going to be reliable and sustainable, making sure that we're going to be able to repair these plans that we're going to actually put in place, because there are going to be hundreds of millions of investments. And the big problem in Cameroon of maintenance, which we have seen, we talked about it last week, buying MRI machines, getting plants like this that we don't have engineers to be able to later on fix them. I think these are all issues that Yauba has thought about. And there is a big problem which I think Raymond also made a comment. I think he's going to comment about it. How do you manage hypoxia, the clinical setting? When we trained, Yauba also was my senior in school, and by a year. And we trained in hospitals at a time where there was no oxygen that was available for us. It may have been available for those who were in the ICU, which was a place which was special for few people. I don't know exactly how the training is now. And we have a lot of clinicians who work in the districts who are unable to even use this oxygen. So once we get these plans in place, and Dr. Braunhilda may make comments later on, our worry during the COVID pandemic, when we're working with WHO in Cameroon and with some of the doctors to try to help them manage this patient, is that we got to realize that healthcare workers don't know how to use oxygen. Meaning even having oxygen is not just having it, but using it appropriately was really a big problem. So I hope, and I know he's going to incorporate this into their strategy to help guide our healthcare system, the minister and everyone else, so that once we get this oxygen, we'll be able to use them appropriately and we'll be able to sustain them. So I really want to thank Dr. Yauba for what he's doing and for the wonderful presentation and for the way forward, because in order to solve a problem, you must first define it, which they did. They did a little bit of field research and they have understood the problem. And I think we are going to have a very wonderful time and discussion with him and the way forward and see how we can help. And he has also asked for help from the diaspora, which is a wonderful thing, Elvis. Thank you.
Thank you so much, Mono. Thanks for your comments. And I want to say that this is really great work, Dr. Yauba. Just like the chair said, the first thing is being able to define the problem appropriately. And you've done really an enormous work to define the problem. And this is how you influence policy. If you define the problem in such a way that the policymaker can actually see the magnitude of the problem, then it is easier for the policy people to prioritize this. And I think that you have succeeded in your work to make the minister or the Ministry of Public Health to prioritize access to medical oxygen as a very important aspect of the healthcare planning. And I can see from just setting up a committee to work on this has already shown proof of the fact that this is already in their priority list for things that has to be done to improve the healthcare system of Cameroon. And last week we had last 2 weeks we had a presentation on access to diagnostic radiology in Cameroon. And it's interesting that all the topics we are having now in the town hall are topics that has to do a lot with equipment, purchase of equipment and very expensive equipment and all. And we've been having all this conversation around maintenance, and all the talk is always around maintenance. We had last week a testimony that an MRI machine has not been functional for almost 11 years in a particular hospital back home. We heard about situations where, you know, a machine breaks down and they have to bring in experts from abroad. And we learned from Dr. Kennedy Foyong's presentation last week that it is important for a procurement process to make sure that all manufacturers are able to actually sign very good deals with the country such that they can come and train technicians in country to be able to manage or maintain this equipment rather than import them each time an equipment breaks down. And I think just like Dr. Muno said, you might have had some thoughts about this. I will give you the time to just take a quick reaction to some of the comments from the moderators before we call Dr. Braunhilda to start the questions from the hall.
Great, great. Thank you very much. So, when, when I travel with my supervisor to a conference, I always answer the simple questions and refer the difficult ones to him. So this time around, I don't know who I'm going to refer the difficult questions to. So perhaps Mono or Elvis. So if there are some questions that I cannot answer, please I'll refer those questions to you. So now there are a number of things a number of issues that have been raised, which are really, really pertinent. The first one is the entire oxygen ecosystem, which I think Luisa was talking about. The commodities themselves, the people, the procedures, the end users, the patients, the repair and maintenance, and so on and so forth. So it's quite a lot. But the good thing is that we actually understand the specific actions that would need to be made for each of the areas. One, if you take the issue of concentrators, what we tend to see following the concentrators that were procured and donated by some organizations, as well as donated by bilateral partners. At the Ministry of Health, there was some sort of a blanket decision to do some sort of an equitable distribution. And what happened is that for the majority of health facilities, those located in rural areas and in areas without electricity, those concentrators reached there and they could not function. One, because there is no electricity to drive the functioning. Second, people have not been trained. So that is really like one of the challenges. But now we do understand all of these things. We have kind of segmented the country, and we know which equipment will be appropriate for which health facility. And that is why I showed this slide, the decision-making slide on the primary sources of energy, the primary source of oxygen, and the secondary source of oxygen. Where there is no electricity, the best available, the best source to use for oxygen is bottled oxygen. That is a cylinder. So we have a decision tree, and we are kind of working towards that. The second thing is the management of oxygen plants. As you know, oxygen plants are quite expensive. And a big oxygen plant, 80 normal meter cube, will cost about $1 million US, right? And then if you want to calculate the operating cost or operating expense, you should be somewhere between 30 to 60% of the initial cost of the capital expense of the plant. And in the context of Cameroon, it becomes a little bit complicated in the sense that Cameroon has a number of geographic zones, right? Because this plant, there's a number of considerations that you need to take: altitude and humidity. So in a place like Douala, the mechanism for extracting oxygen from the ambient from the normal air should be different from the mechanism that you use maybe somewhere in Yaoundé or in another part of the country. Because in Douala the air is humid, right? The air is humid. So when you absorb the air, you need to dry it first, right? So you need a mechanism for that. And then if you go to another region, you will certainly not need that, right? You certainly not need the mechanism. So we now understand all of these things, and for the plants that we are acquiring, we have taken in consideration these specifications, and that is really like a big achievement. Otherwise, plants will fail on the first day they are installed. So we are quite sure that most of the plants that will be imported and installed in hospitals, they will not fail on the first day. And then the third important thing is how to manage these plants, right? We talked about the operating expense, which is about 30 to 60% of the capital expense. Where are we going to get the funding for this? So currently, the thinking is to establish some sort of public-private partnership. So we plan to go and meet the people at GCAM, at least present the problem to them, and then get the people who can actually invest, who can manage the plant. right, who can manage the plant and then sell the oxygen to the hospitals and then recoup the margins from whatever they have recoup margins, and these margins can be used to actually run the plant. So the bottom line here is really to look at make a management system that is going to work, right? Because we have seen the country currently has I think 9 PSA plants, and just about 3 are functioning, 7 are not functioning. So we don't really want we don't want to run into that sort of situation again. So we need to think in another way. And currently our current thinking is to incline the management towards a public-private partnership, and I'm quite sure that might work. It has its own pros and cons, but I think for now that is the most suitable management option that is resonating within the task force and also within the MOH. And then you also talked about management. Yeah, we understand it's a problem. I think the situation has not changed from what it used to be in 2005 and 2006. You go to a hospital, you don't see a reference hospital for that matter. You don't see a pulse oximeter, right? People get trained and they finish school and they don't know how to use they don't know how to administer oxygen. I think myself, I actually learned how to administer oxygen when I was in the Gambia. That is when I actually learned how to administer oxygen. So that gap is still there. So what we plan to do over the coming weeks is to develop a training plan, right? And then train people from regional hospital and also district hospitals. So we already have funding for that. At least to train about 50 people from regional hospitals. That is going to be a hands-on training. And then about 500 people from target district hospitals. So I think we are currently planning towards that. So by so doing, I think we are going to like improve on the clinical skills on those people, on those staff who are taking care of patients in such a way that they will be able to diagnose and also manage patients. And then we also have plans to buy pulse oximeters and then send to those health facilities. So that is going to have, but it's not going to address all the problems. There is still going to be a need. There are about 6,000 health facilities, and we can only do that much. Then the last question the last thing I wanted to perhaps tell Lisa is that the MOH is actually taking this seriously, to the point where they have created a budget line for medical oxygen, which actually shows good political and or goodwill from the politicians and as well as also from the government. So, but now the next challenge is, we have the budget line. Are we going to mobilize the funding, the necessary funding? And if we mobilize the funding, is it going to be deployed and not used for other things? So let me stop there for now and see whether there are additional questions.
Thank you so much, Dr. Yauba, for enlightening us again. And we really appreciate everything that you do. It's really not easy to get everything going in 1 year. So it's one step at a time. And again, we're really, really happy that that this has started in a very good footing. But without taking much time, I'll call on Dr. Brown-Hilda, and she will ask questions and probably throw a little bit more perspectives on things from the intensivist side. Dr. Brown-Hilda, over to you.
Well, thank you for calling upon me to ask questions. Thank you, Dr. Yauba. You actually did an excellent presentation. I may ask, I was on, but kind of distracted doing some other stuff. So maybe there are some things that I missed. However, I am actually pleased and impressed that there is, some plan in place to help with this oxygen supply shortage in Cameroon. However, I worked with, I think Dr. Foma mentioned it, we kind of collaborated with our colleagues back in the Northwest a couple of months ago. This was an eye opener for me. You know, unlike Dr. Foma, who has worked in Cameroon, I've not practiced in Cameroon, so you know, my expectations were a little bit different from his. And what we got from our collaboration with our colleagues back home, there were a few things that we could take out of that experience, and one of them, you know, some of it which Dr. Former mentioned, the even to know how to use the oxygen, when to use it, how much to use it. In fact, we had situations where patients with COVID had saturations in the 30s, 40s%, and some of our colleagues were kind of apprehensive using oxygen. In fact, so sometimes they'll actually they'll be scared to go above a certain level of oxygen supply because they're afraid of oxygen toxicity, and say the patient may be on 8 liters and they're saturating 55%, and they'll actually maybe decrease the oxygen because they are scared of that. And so there is really need, and you know, we kind of helped out to you know, as much as we could, and also understanding that there are limitations as to oxygen supply devices. I know I heard about the oxygen plants and oxygen concentrators and cylinders, but maybe I missed it. I'm not sure what devices are available in Cameroon. I know they have the regular nasal cannula. I know they have the non-rebreather mask, which we had encouraged physicians to use if they had to use it, because we needed saturations which were decent, at least above 88%. With from what Dr. Yalba said, they also have provisions for pulse oximeter. But you know, if I could suggest, or maybe you know, this is already in plan, do they have provisions for ABG machines? Because like I think you just mentioned, in order to adequately manage this patient, so if we're planning to do something, if we have to invest so much amount of money to get an oxygen plant and even concentrators, we have to be able also to train to provide the providers with adequate basic, you know, if we can afford for an oxygen plant, I'm sure we can afford for an ABG machine. Also, do we have, besides regular nasal cannula and a non-rebreather mask, I think there's need for something like non-invasive mechanical ventilators, like a BiPAP. There's need for a CPAP. Those are some of the things that you may still have the oxygen supply, but if your patient is really hypoxic, that oxygen, you need those devices like your CPAP and your BiPAP CA, which is the same machine. You can just change the setting, which is what we have actually used here. Or even the high flow nasal cannula oxygen. You don't have to have a whole lot, but you need some of those devices too, because you may have everything that you just mentioned within your oxygen may be available. But if you don't have the appropriate devices to give the patients to supply it, then it may not end up helping the patient. So I think I'm not sure how much they budgeted for supplies, but they should consider things like a CPAP machine. They should consider things like high flow, because those, yes, they do need electricity too. They should consider an ABG machine, because it is, even if you don't have a whole lot, you can have maybe 1 or 2 in some of those hospitals and it'll still help besides your pulse oximeter. Now, also in terms of training, and I'm also happy that you mentioned that there will be training, personnel for this, because I think this is very, very important. If the personnel are not trained to use the devices, and I hope that they will also have the willpower to do that, because I'm saying this as an example. I had actually volunteered to help, one of the regional hospitals with whom we're working with, to even help them with they have the CPAP machine, but their limitation was that they didn't know how to use it and they're waiting for it to be set up. I volunteered and tried to follow up. Up to now, nobody reached out to me. So I was actually said, I was ready to help them out to set it up, to use it. And that can save lives. And even the ventilators, I know they also have ventilators, but they also need personnel how to use it. I know they have anesthesiologists who can intubate, but the question is, do they know how to use the vents? And so some of us actually out here have given our availability that if there is need for help with educating physicians, our colleagues back home, on how to use those machines, we're available. So, I don't know if Dr. Yauber can give some, respond to some of the things that I mentioned about if they budgeted or if they'll take into consideration some of what I mentioned. Thank you.
Thank you very much, Dr. Brown-Hilda. So I'm sorry, I forgot to introduce who Dr. Brown-Hilda is. She's a pulmonologist and a critical care doctor in West Virginia. And Dr. Dr. Brown-Hilda, thank you so much for everything you've been doing so far with regards to managing COVID-19 in our country, particularly in the Northwest. And so, Dr. Yauba, please, over to you.
Thank you very much, Dr. Brown-Hilda. So I think with regards to budget, I think we had a very, very exhaustive budget. We kind of previewed the acquisition of basically most of the items you listed, and I think in the Global Fund proposal, we kind of included a CPAP and a BPAP and also a number of things, including wall dispensers, right? You know, it's very common to go to hospitals and then you don't see these wall dispensers like as you see in the US and so on. So you need to move the bottle oxygen from one bed to another. So now that we are thinking about putting tanks and building TSA plant, we did make provisions for those wall dispensers as well as all a number of the items you cited. I don't have I cannot remember the details, but I know we were really, really exhaustive in our budget. So the only limitation we may have now is really mobilizing the budget. As I mentioned earlier, 94% of the budget is directed towards Objective 2, acquisition, deployment, deployment, installation, and trainings on equipment. So far, I think we have been able to mobilize some funds, but I think that is going to be a limitation for us. But most of those items you have cited have been included in the budget. We'll continue to work hard to mobilize funds, and perhaps if you know of other opportunities that other funders who might help us, please let us know. We'll be happy to know. We'll be happy if you could link us to those funders so we can contact them, prepare the necessary proposals and so on. So in terms of training, I think that is really, really, the points you are raising are very, very important. And really, I will really appreciate your support in developing training modules and also perhaps training of trainers, which we will organize maybe sometime later this month or early next month. So I will discuss with the emergency physicians in Yaoundé, at least schedule a date, and if you are available, you can contribute toward through an online platform if you are available.
Okay, yeah, just reach out to me.
Yeah.
So
also the training modules. So I think if we may perhaps solicit their help when it comes to development of training modules. So I'll certainly get their email from Forma or Elvis, and we will be sure to send you an email requesting for support, either to review or to request for materials that you may have. So thank you. Thank you again for the excellent support you are providing to Cameroon. We are really, really appreciative of what you are doing.
Thank you. Thank you for the work you do.
All right, thank you so much for that response, Dr. Yauba. So we have Dr. Raymond here, and since the presentation started, he's been very eager to share his own perspective as an intensivist in Cameroon. So Dr. Raymond, if you can turn on your mic, you're muted, and over to you. You're still muted. Sorry. All right. Thank you.
Is that better? Sorry. Yeah.
That's so. We can hear you.
Okay. Cool. I was really very touched by the presentation today because as an intensivist who's worked in Cameroon for the past 5 years, it's been a hectic challenge getting access to oxygen. I mean, it's really been hell for us, and sometimes we see many of our patients arrive and there's pretty much nothing we can do for them because we don't have enough oxygen to take care of them. And I think the perspective that the presentation is oriented towards the need for oxygen based on COVID, but I would assure you, as an intensivist, oxygen is our fuel. We can't work without oxygen. It's one of the first things we work with to keep our patients all right. And I'm really very happy that Dr. Brunhilde gave a little bit of perspective on what will be important, because yes, it's good to have 11, 12, 13 oxygen plants is a great thing. But I think if the endpoint, which is delivering oxygen to the patient, isn't effective, then the whole investment in getting oxygen would have been a waste. She touched on Dr. Brunhilde touched on certain aspects of acquisition of equipment and all of that. And I would just like to, get you to know what kind of difficulties we face. The first thing is, from the oxygen delivery perspective, yes, we have nasal prong oxygen. We don't have high flow nasal oxygen. Some centers have non-rebreathing masks, but most of the time, many of the staff who have them don't even know how to use them, as we have said, especially in the emergency departments. Many people, they are present in the hospitals, but they're just not available at the emergency where the patients are received. So the other instruments, such as the intubation, the endotracheal tubes, the laryngeal mask airways, or all the other things that could be used for airway access, are technically very difficult to come by. And you'll be surprised that, and it makes my practice even very sad, that sometimes patients come to the hospital and you have to prescribe an ET tube for them to buy. Like prescribe an ET tube for the family to buy and bring for their patient to be intubated. What happens in that time? It's really a very difficult thing to come by. That is just from a delivery perspective. Coming to what I would call economy and optimization of delivery, because as she said, practitioners who are faced with patients who come and they are saturating at 45%, 50%, we have such patients who come, and you have a practitioner who has just 100% oxygen to give to a patient, and he knows there are troubles with oxygen delivery. The problem of the arterial blood gas and saturations and all of that are a big problem. I would honestly tell you that even we as intensivists, it is hell working with the patient. You have to intubate. You don't know what their arterial oxygen levels are. You don't know how to work on the amount of oxygen to give them, which in one aspect is a problem, because if you have to intubate someone, sometimes just knowing the oxygen saturation makes you know how much of the oxygen you need to give them, and complete the other one with air, which is the next thing I wanted to put as a question to Dr. Yauba, because delivering oxygen at percentages lower than 100% needs mixing up with air. So you can have all of these, but if the structures, if the centers are not equipped with air compressors, how would their machines work? How would you be able to bring down those saturations? So I think as part of the initiative, it's good having these things. It's good having the plants, but it's also good to think about probably providing for air compressors for the different centers that are going to receive this oxygen, so that where they have ventilators, they can be able to give 40%, 60%, 80% oxygen to the patients that require this oxygen. This oxygen, the air compressors are really a very important aspect in reducing the amount of oxygen that we use. That's why I spoke of this second aspect, which is oxygen economy and optimization of delivery. The next thing is obviously the monitors we have. We need to equip the hospitals. I think Dr. Brunhilde spoke of that. And among the monitors, one of the most important things for me will be the use of end-tidal carbon dioxide. It may seem completely off topic, but this single use of end-tidal carbon dioxide, especially for ventilators, enables especially in the domain such as in theater, because remember, oxygen was a problem even before COVID. So COVID probably just exposed the problems we've been having a long time ago. And this is shortage of oxygen in important areas of the hospital, especially in the maternity, for ladies giving birth to children, in the neonatal ward where children may need CPAP or BPAP or high flow oxygen to help them cope with the different stresses that they encounter. So getting the end-tidal CO2 is a good element, like monitors that monitor amount of CO2 expired, enables you to use a technique which we call in theater low flow ventilation. I don't know, there are probably other anesthetists here to understand what I mean. That is technically recycling the amount of oxygen somebody breathes out and giving it back to them cleared, void of all the CO2 and all the gases and everything that expired. This means that for a whole procedure, I'm taking, for example, the theater aspect, which is not necessarily the ICU aspect, but which uses up most of the oxygen in the hospital, is that if you're using oxygen and you're giving your normal tidal volumes to your tidal volumes or your minute ventilation, you end up giving about 20 to 30 liters for a 15-minute procedure to a patient. Meanwhile, if you could have something that monitors your carbon dioxide so you know what your patient is getting back, you're capable of giving as low as 5 to 15. That is almost half the amount of oxygen that you would give to someone. I think this is an important aspect. Equipping all the domains where oxygen will be used in the hospital, be it in the theater, be it in the ICU, be it in the neonatal ward, with elements enabling them to be able to know what is the amount of oxygen they're giving and to economize. I'll end by talking about arterial blood gas machines, which I would say, as someone who has worked in 5 years, it's been a very difficult thing to come by. I would say honestly that it's shameful to say that in 2021, there are only 2 arterial blood gas machines in the whole of the town of Yaoundé, and I'm saying this with extreme confidence. And one of them is a portable arterial blood gas machine, which obviously needs calibration frequently, and it's not like the one like the station one where you could actually get internal calibration, which makes you understand the gravity. I don't know about Douala. I don't know how many centers in Douala do arterial blood gases. Probably the General Hospital in Douala does one. I don't think Hospital like Kentini has one yet. Probably 1 or 2 other centers in private. But it is really alarming that in 2021 we should have people practicing medicine which is supposed to be at a high level, and we don't have arterial blood gas machines. So I think if this is probably my own way of putting out the advocacy for oxygen. Yes, we need oxygen, but we need air to be able to give healthy amounts and healthy percentages of oxygen to patients, and we should be able to know exactly what the patients need. Sometimes giving 15 liters of oxygen through nasal prongs, it's almost wastage, because as the patient breathes in, when they're breathing out, whatever was coming in goes out. Giving a simple face mask, it comes in, it's wasted. But if you know that this patient has low saturation, somebody at 40% will clearly need to be intubated eventually and given oxygen at a proper level with economy based on the other needs of the hospital and the patients that are there. So I think this is really a very important topic. I really applaud the initiative of the team led by Dr. Yaoba, which I really feel that if this project comes to completion and that all the other aspects that are related to it, especially the delivery aspect, as Dr. Brunhilde insisted, if these come to pass, we would really be able to not just manage our patients from a COVID-19 perspective, but be able to solve a lot more problems in the different hospitals. I mean, many of us here have family members who live from hospital to hospital, carried in a taxi, they're not breathing well, and end up at the end of the day turning around for 12 hours finding oxygen. It's really aching for us who, as practitioners, would like to give the best, but would need the tools to make these happen. So thank you very much for the presentation. Thank you, Dr. Foma, for this great initiative. I know I've been absent for a while, but I mean, I've been trying to handle things at school. Remember, as I said, I'm trying to read a bit and step up my levels, but I mean, I really appreciate the initiative, and thanks everyone for watching and being part of this.
So just to add something before Yaoba answers that question, it's just a little question too for you. When you were in CSU, did the blood gas machine work? So we had one in CSU, and it's just, I did pathology in CSU, so I know what I'm talking. We had a blood gas machine in CSU, which worked from time to time because Professor Cam Maurice was there, but nobody asked for a blood gas. I could assure you it was not asked 80% of the time the machine was sitting there. So it goes with a lot of, it's later on in my training here for internal medicine and other things that I knew how important that machine had to be used. It was there, we could run it. There were times it was not functional, but a lot of times nobody asked for a blood gas. So the machine was lying there in the biochemistry lab in Professor Ngongang's lab. It's one of the first machines before you see that. I can still remember its position, arterial blood gas, but we ran it about 3 or 4 times. Then there was an issue with the bulb and everything. So just to make a bit of throw a bit of light into the question, and Yauba already spoke about it, about training, which they have incorporated a lot in their plan. Thank you.
Can I also quickly say something along the same line with what Dr. Raymond said? Can you hear me? Yes, okay. So I quickly just looked up prices, of some of those devices, and I really pray that Dr. Yauberg, he was just the right person to be presenting today. And given that he also is involved in all of this projects, for instance, the high flow nasal cannula machine, they are all like less than even, is it $5,000, $3,000, the CPAP machine, the ABG machine. I just quickly just looked it up. The most expensive I saw was $12,000, which is probably a bigger one, So given the budget that you have, if there's one thing that you really have to help us is to actually ensure, because you already said it, that you think that they budgeted some of those things. But if you can even follow up on it to make sure that, yes, there may be a CPAP and a BPAP, but to follow up to make sure that they have something like this, Dr. Raymond just said it, he's on the ground. ABG machine, the end-tidal CO2, yes, the end-tidal CO2, what he said was true. It helps if you are able to know what the patient is, how much ventilation the patient is getting, then that can help you to tailor, even you titrate even your oxygenation and overall management for the patient. So all those machines that he mentioned are not very expensive compared to the plants and the concentrators. So if there's one thing that you can help, especially the providers back home, is maybe to double check and make sure that they do have, because they may have the BPAP and the CPAP, but the ABGs and even the high flow, if there's a way that that can be looked into, that, because that's the new thing now, and it really, really does help a lot. So I just wanted to add that some of these machines are not very expensive, given that they have some budget to allocate to them. Thank you.
Dr. Yauba, I don't know if you have anything to add, or you want to defer to Dr. or Elvis.
Yeah, these are really the type of questions I would direct to Foba and Elvis, because they are very, very difficult. So in essence, we actually find ourselves in a situation where we actually will need to rebuild the entire ecosystem, right? So we look at it from a public health perspective rather than from a clinical perspective. So what we essentially did is that we, with the concept of equity in mind, we decided to target basically all the core things that matter, the core things that will the core things that will make us to have like an efficient and functional system. So we need first of all, we need a policy, right? We need a policy. We need some sort of a regulatory framework setting the standards on what is the minimum that needs to be done for a particular patient at a particular level, right? So what we agreed with within the task force is to, in short, to align the investment according to the health pyramid. So at health center level, what is the minimum investment that should go there, right? So we agreed that what should be done at the health center level is to maybe build the capacity of those healthcare workers to be able to diagnose hypoxia. And once they diagnose hypoxia, they can now refer that patient to the district level, right? And district level, they can also refer critical patients to regional level and so on and so forth. So for the primary level, we need to do a number of things. One, we need, first of all, to update the clinical guidelines. In short, we need a regulatory framework and norms and standards, stating that health centers, moving forward, they must be able to diagnose hypoxia. And then we make all the arrangements to provide them with the tools that they need to diagnose hypoxia. And that is a pulse oximeter. So they will need that. And then in addition to that, they will also need framework for collecting and reporting data on their activities, right? So that's like the minimum we judge to be important at the primary healthcare level. So at the district level, there are also a number of investments that we plan for district level, regional level, and then tertiary level. So all of these things, I think, they are well calculated, they are aligned, and I don't remember very well whether the budget will be whether we did include the things that Raymond was talking about. I remember fairly well that we did include ABG machines, but the other ones about how did you end-tidal machines, I cannot remember. I need to check to see whether those things are included. But what we should know is that we approach this stuff from a concept from the perspective of equity. We want patients to be patients who are suffering from hypoxia to be able to know that they are actually suffering from hypoxia from the first facility they visit. Right? Generally at Raymond, the hospital where you find yourself, you will not see a patient presenting with mild hypoxia. You only perhaps will receive critically ill patients. So from a public health perspective, it actually makes sense, given that we find ourselves in an environment where in an environment with constrained resources, it really makes sense to roll out primary healthcare interventions. By so doing, you can detect those cases early on and then correct the causes before they actually develop into severe and critical cases that will require critical care attention. But notwithstanding, investment needs to take into consideration the 15-20% of patients that will develop critical conditions and that will warrant admission into intensive care units at specialized hospitals. So all of these things, I think they have been taken into consideration in the plan. And the only thing now, my only limitation now is that I don't really remember those things from the back of my mind. So I think I may get in touch with you, Raymond. Where are you based? For my information.
Yeah, so I'm based at I'm based at the Yaoundé Hôpital Gynéco-Obstétrique et Pédiatrique in Yaoundé. That's where I'm based, but I'm currently doing a fellowship in pediatric anesthesia in Cape Town. So I would only return at the end of my training in March. But I'm still actively involved with activities in the hospital and could still, be available to help out with anything that has to do with that. And concerning training as well, I'm one of the lecturers in the Department of Surgery and Specialty, specifically in anesthesia. So when it comes to the aspect of training people in the use of oxygen and all of that, and I could also be handy as part of the team, because it's one of the challenges that we have, trying to change the boundaries of how people have been trained on oxygen management and all of that. So yeah, even though it's far away, I'll definitely return and be available once my training is over, or even before, depending on what you need me to do. But I'm happy to help.
Okay, great. So I will get in touch with you, Brunhilde, and then I can also share with you the list of commodities that we that we budgeted in the plan, as well as those that will be procured by Global Fund. I think at Child we also have some money to procure some commodities, but we always will do procurement taking into consideration value for money. Does this make sense? Does this investment make sense from a public health perspective?
I have a question, Dr. Yauber, regarding what you just said, that if a patient, the patient may go to a district, and then you first said the list of the hospital. I'm sorry if I don't know. Before the district, you have the primary centers. Yes, And so one of the is there a way, is this, let's say a patient goes to one of the primary centers and they have their level of care has to be, they need more level of care, and they have to go to, say, the regional hospital or one of the districts. How do they get transported? And the reason I said so is because with my little experience that I had with colleagues back home, I came to understand that sometimes the challenge may also be transportation. So even if, for instance, say a patient goes to a district hospital and this patient is severely hypoxic and they can't handle this patient, the patient needs to be transported to regional hospital for better management. They probably need the ambulance. Is it readily available? Is that something that's going to be from the patient's pocket? Or are there going to be provisions for this too? Because although we talk about, yes, supplying different facilities with what we think they need, we also have to remember that sometimes the problem may not only be what they need that is available. The problem may be how do they even get to the next hospital, and do they get transported by private car if they're hypoxic? I don't know. That may be a challenge as well. So I don't know if that is something that it's been factored in your project.
Yeah, absolutely. You're absolutely right. I think this is really one of the areas or one of the questions we debated extensively on. Should we include medical ambulances in the strategy or not? There are some guys, and the emergency physicians, they think that it makes sense to include ambulances in the strategy budget for that, which they did. They actually did. So if you look at the strategy, they actually previewed the acquisition of ambulances, 10-liter oxygen bottle, and so on and so forth. But the challenge is actually the scope, right? The challenge is actually the scope, because in a country like Cameroon, we can actually count the number of ambulances. We can count the number of ambulances. So if you are talking about, if your vision is really to ensure that any patient who develops a condition that will require medical transfer from one hospital to another, then I think the current investments may not save that goal. And what is currently being done here, what is currently being done is that the patients will need to figure out the means of getting to the facility. So most often they have to pay for private transport, which is unfortunately sad. They have to pay, and we all know those transport cars, they don't actually have provision for medical oxygen, and can actually be like an important contributor to death. I did ask one of the anesthesists, one of the emergency physicians, to try and come out with local data. How many patients are referred and how many patients are referred and they fail to get to their destination hospital because they lack the care in between the two hospitals. So that's the question I asked one of the emergency physicians. I don't know whether he's going to work on it, but I think having that sort of data might be important and may help us better engage the policymakers and also funders, because it's really a neglected area. No funder wants to fund this area. They say it's the responsibility of the state, and the state doesn't also recognize it as a priority. I think in Cameroon, I think they have made some progress. They have made some investments, at least, to provide ambulances that can cover road that can provide coverage for road traffic accidents between Douala and Yaoundé. I don't know very much about Bafoussam and Douala, or Bafoussam and Yaoundé, but I know about Douala and Yaoundé. But the investment is still minimal. So you're absolutely right. I think it's a neglected area, and there is that need for us to start raising voices for people to invest, for people to give this area the attention it deserves, be it the government, be it the clinician themselves, and as well as potential funders.
Okay, thank you.
Thank you so much, Dr. Yoba, for answering those questions. And thank you so much, Dr. Brownhida. I want to, but Brian, will you want to check the temperature in the hall while we allow Yoba to get his breath a little bit before we come back to him? Maybe, Brian?
Yeah, I was just scouting through the town hall. I saw one of my great mentors and support, Dr. Ebai Eseme. I know he posed a question in the town hall. Really wanted to hear his voice, and I know this is probably his first time here in the hall. If you'll be willing to share a few words with the town hall, Dr. Ebai. Oh, you're muted if you're speaking.
Yeah, thank you, Brian. Can you get me?
Yes, we can get you.
Hear you.
Can you get me, please?
Yes.
Okay. I'm sorry, I can't really show my face because I'm in the hospital. Thank you, guys. I'm so happy to be with you. Thank you, Mona, for this initiative. It's my first time to participate. Thank you, Yauba. It was so good to see you again and watch your presentation. But I just have one question. You know, the issue is I'm just having some problems with the issue of politicians. Have they put this stuff in the budget for November?
Yeah. So I would like to introduce Eba is my classmate, and also he's a surgeon, and he's involved in using a lot of oxygen and works in Yaoundé. So Eba really knows a lot about this problem, and he was our class leader during the time when we were in Q. So it's a pleasure always meeting you, Ebaro. And Yauba, please, you have the floor.
He really wanted to give Dr. Yauba a little bit of time to take a breath and maybe drink a glass of water before.
Maybe Yauba should be getting some rest while we get the temperature in the hall. But take note of that question. He's asking if this part of that budget has been submitted for the budget for next year that has to be voted in the National Assembly in November.
Awesome.
Okay. What I know, in short, I cannot confirm, but I had last when was that? Last Thursday, when I spoke to the new director of finance at the Ministry of Health, who also happens to be the vice president of the Oxygen Task Force. So she did notify me that a budget line has been created for medical oxygen, that the minister specifically insisted that we should have a budget line for medical oxygen. So the amount, I don't know. I haven't seen that written in any document, so I can only say what she told me. But I can verify. I can verify maybe during the course of next week, just to confirm that part of the, in short, things that we enlisted in the proposal, not in the strategy, have actually been have actually been inputted into the state budget for 2022.
Okay, that would be good. Thank you so much.
Brian, any more people you want to check with?
It's really great talking about oxygen. Really been thrilled to have Dr. Yauba today, and deviating a little bit from COVID and talking about this is really exciting with so many things happening globally. Just wanted to say thanks again to everyone in the hall. I see a lot of people that I recognize. I see Dr. Kasna Sangwa, who is also, I think, an anesthesiologist in training. Was wondering if you wanted to say a few words to the hall.
Good evening, everyone. Can you get me?
Yes, we do.
Yes.
Hello. Yeah, boss. I'll be following for arriving home in about a few minutes. Can I maybe intervene when I'm at home?
Yeah, definitely. That's totally fine.
Okay,
Yeah,
thanks. In about 5 minutes.
absolutely. It's always great hearing your perspective, Dr. Carson.
Yeah. Thanks.
Yeah, Donald Chapman, I see you're in the hall as well. Will you be you okay with saying a few words to the town hall?
Okay, Brian, thank you so much. I'm sure these few minutes have given Yauba some time to regain his breath, and we'll be coming back to you, Dr. Yauba. And there is a question in the chat which has already been asked, but I would want to follow up with another question. You mentioned that when you look at the oxygen need in Cameroon during your assessment, you saw that we are able to boast of only about 500 cylinders of oxygen in the entire country, despite the fact that about more than 1,200,000 cylinders are needed. In your situation analysis, did you come across any data on mortality related to oxygen deficiency? Or this is not documented at all because of the absence of it?
I think it will be difficult for me to say with certainty, but I have asked a number of emergency physicians to actually look into this. So some have promised to get their students to work on this for their MD thesis.
Great.
But currently, I haven't seen any data that is any data or publication that talks about hypoxia-related deaths in Cameroon.
Thank you. Luisa, you can take it back and check if there are other questions before we plan to wrap up the session.
All right, thank you so much. So we're really having a great conversation here, and I see Dr. Muno is eager to say something again. But before I call on our chair to say something, I really just wanted to recognize Mr. Nji. I hope I'm calling it properly. He just messaged in the chat, he's not a healthcare provider, he's a teacher. And I just wanted to really echo the words of our chair, that the town hall is for everyone, as in everyone whose main goal is to achieve great health for our country. So feel at home. We really appreciate you coming in and staying and following all the presentations. So if you have any questions, please feel free to raise your hand and ask. And anything you don't understand, please just feel free to raise your hand and ask. Dr. Foma, over to you.
Luisa, thank you. I am actually putting my hand up to call a series of people that I want to acknowledge their presence and see if they have contributions. They are back at home, and I know a lot of them here. It's the first time I'm seeing Dr. Kum Waters here. I'm also seeing Dr. Fatimatu. You can ask your questions in English or in French. You can unmute yourself and say hi to the town hall. And I'm also seeing that we do have Dr. Henshaw. These are all people who know exactly how, Mandy Henshaw, they know exactly how the system works, and they're able to give us a lot of contributions concerning how to better help access oxygen in our present situation in Cameroon. Before I ask my question, there's also Dr. Fonedwin. I see a lot of people who are here, and please, you can always just say hi to the town hall, or if you have questions or contributions, you can please give your inputs. Thank you. I would start with Dr. Kum Waters, please, if you can unmute.
Hello. Thanks to everyone. It's a pleasure to be connected today. Mr. Mono, I don't think you are serious if you say you see me for the first time. I know each time we meet, you always try to pull my legs. I think I attended, this is my third time connecting. I think I attended a forum, and the one Professor Angwafo attended, I think I was present. And unfortunately, because of conflicting agenda, we've consistently been inconstant. And I think today, again, I joined late because when I received the mail, I think the topic was so interesting. And as we all know, history has it that I work in the West region of Cameroon. I work with the Cameroon Baptist Convention. I'm into HIV/AIDS. I'm a public health physician, and so we are struggling to see how we can help Cameroon reach epidemic control. And when this COVID stuff came up in March last year, I think as a regional manager, we're actively involved. In fact, my drivers are the ones who transported COVID samples to Centre Pasteur, which was the unique testing center, until the DREAMS lab in Chang and the TB reference lab in Bamenda was able to do so, and we continued doing the transportation. So we supported to a great extent the West region in combating COVID, and I think the data we had, we showed that a lot of surveillance and a lot of active search of cases was happening, was partly due to our work. But we did that because we had to work to make sure that Cameroonians live healthily, and also the population, which was like our raw material, we're into HIV, that we sustain them and be able to identify those who have HIV and put them on treatment so that
Maybe he has some network challenges.
Yeah, we lost Dr. Com Waters.
Okay, maybe we move to the next mono so we can be able to wrap up by 3 p.m.
Yeah.
So, yes, I'm back. Just to round up and say I'm glad to be here. I joined during the discussions, and I want to thank Dr. Yauba for the great presentation. It's been a while we moved away from clinical health, but I think as physicians who are in country, from time to time, our attention is called family members, friends, colleagues, on how, on where oxygen can be provided to clients. And it's generally very disturbing when when they get to us and we are unable to give them anything, tell them anything really good. But I think COVID, the coming of COVID too, has to a greater extent contributed to improving the situation. I may not have the exact figures, but I think we attended a regional coordination meeting in the West region last week, where the delegate actually made promises. The region received a lot of oxygen concentrators, the cylinders, and maybe other material, technical material that I may not know. And I think this forum is very important, and we'll try to henceforth attend as much as possible to see colleagues, to learn, and also to contribute our quota to overall improving the health condition of our countrymen. Thank you very much for the opportunity. Over.
Thank you very much. And Dr. Mandy Henshaw, Elvis, that's the others may put up their hands if they want to talk. I'm just pulling the legs of a lot of people here, so.
Yeah. Hello, everyone. I think it has been a very important presentation today, and I really never wanted to miss this. I'm in Cameroon at the moment. I'm Dr. Henshaw Mandy, public health physician and a vaccinologist. So I work with CEPI, but we do a lot of the vaccine side. So we are more on COVID vaccines.
We lost Dr. Henshaw too. So
development. But presently, I worked in Cameroon as a chief medical officer as well. So I really understand. Are you getting me?
Yes. Right.
Hello?
Yes, we hear you.
Yeah, sorry about that. I'm in Cameroon, so we can get that. So I'm based in Norway, I'm in Cameroon for my holiday. So I think it has been a very important conversation. One thing I would just add is that we know that the government and maybe NGOs might not just looking at the gap they need. They might not be able to fill this need. So I was happy to.
Great, we lost him. And maybe for the sake of time, we'll move over to call on Yvette. We see Yvette, your hand is up.
Thank you so much for giving me this opportunity. I'm a recent graduate. I graduated with a doctorate degree in nursing practice. I'm currently in the United States of America. I haven't started practicing yet, but I've worked mostly as a nurse, and I've been working throughout with COVID patients as a nurse. So my question is, I know Dr. Yahuba talked about training. So is the training more just for physicians? Because I feel that it's also really important to have like respiratory therapists who will be involved in doing like the ABGs and also to monitor stuff. And because the physicians will probably be really busy, and having that someone like a respiratory therapy who will go in and be able to monitor stuff and then communicate with the physician who would then go ahead and do the prescription for the implementation. I don't know if they have programs in public universities like in Boya or Yaoundé that have training for respiratory therapists who will go out there to be able to manage all these devices, and also help with management of the of maybe hypoxia and stuff like that. That was just my question. Thank you.
Yauba, you can come in.
Thank you very much. So in terms of the training that I was talking about, it's essentially going to be a 5-day training, hands-on. So we want to regroup clinicians, not only doctors, but nurses as well. Because we know in Cameroon, if you go to a regional hospital, or even a regional hospital, if you go to a district hospital, I think the most you can find is about 3 doctors, right? So it's very hard to find more than 5 doctors in the district hospital, particularly if the hospital is out of Yaoundé and Douala. And also in many regions, the most you can find is about one or 2 anesthesists, right? So the training that we are going to do, the training that we plan to do, will regroup 10 people per hospital. And for the regional hospitals, we will target 5 people per regional hospital, and this will include nurses and at least a nurse and at least a physician. So for the district level, we'll also do the same. And I think for the district level, we will be inclined to having more nurses than doctors, because the number of doctors is usually quite small. So in terms of pre-service training, I think that is really an interesting question. Currently, I know we do have a number of medical faculties in Cameroon. I don't know their curriculum, but I think having to integrate this emergency care or whatever you call it into the curriculum of those universities will be very, very challenging. We have tried that for other services. It has not worked. We have tried that for vaccination and even HIV, and it has not worked. So I really wonder whether trying something on emergency care is going to work. But if you have ideas on how this can work, you are welcome to share. We have a very good relationship with the University of Boya, so it might be possible to initiate discussions with them. But I can't promise that it's going to work, because I know how difficult these things are. Another innovative thing that you can do is really to create a YouTube channel, right, where you could disperse those trainings, and we could have to disseminate them within the different faculties. And if people are interested in knowing or learning about certain things, at least we can refer them to those channels.
And just to follow up on that, I would come in to say that what drives the people to get into certain profession is the demand for their services. And you've presented a very ambitious plan for access to medical oxygen in Cameroon. And of course, from Yvette's point of view, this will really necessitate the service of a respiratory therapist or technicians. If we have this training by a private university or school, we understand that training for nurses in Cameroon, I think, is really highly enhanced by the private sector, with St. Louis in Bamenda training really a very large number of nurses every year, and other private nursing schools. So the question is, if the private sector takes on maybe creating this curriculum and opening this department to train these technicians, will they be able to have the opportunity or the jobs for them to be integrated to provide the services that they are trained for? Because I think what drives people to get interested in this field is also the demand for their services. And so I think we might not look at it just from the point of public universities. We can look at it from the point of generating the need for their services and say, okay, Cameroon needs a service of 100 respiratory therapists, and we want to open this opportunity for any school that is able to provide this training that we can actually recruit. And I think most of the private schools can take on the initiative. And so maybe in the thinking process, we can look beyond just the public universities and to look at if the private sector could be able to maybe provide this training. And maybe Brownhida, you want to add something on this? You have the floor.
Yes, actually, our nurse practitioner is very, very right. Sorry, is it Yvette?
Yvette.
So sorry, but yes, yeah. So she's very right. In fact, that was actually on my to do the questions I had also to ask when I meant training. Your respiratory therapists are very, very important to have, especially it should be they should be a big part of this process. Sometimes, in fact, for instance, in the US, not that I want to compare the US with Cameroon, the respiratory therapists are actually, they are more familiar with the devices, even more than the physicians. And they can be a really big help to physicians, from doing a blood gas, arterial blood gas, to operating the CPAP machines, the BiPAP machines, the oxygen, supplies and all of that. Yeah. So, yeah, it may be a challenge, but I'm not on the ground, so I don't know how much. If Dr. Yauber knows you may know people, or you may even talk to the minister. I'm not sure. I think that's a branch in medicine that is highly needed. That will serve in Cameroon, especially if they've come up with this bold initiative to invest in oxygen supply. So if they're investing in oxygen supply, maybe that may be something that you can actually communicate with your team, that an integral part of oxygen supply and improving the health system in that regard is to actually think about a respiratory therapy school, which I think you have a lot of people who will be interested in that. A lot of students will be interested in that, because their training goes beyond just ABGs. They actually are a big part of the ICU team management or pulmonary management. So I think that is actually something to think about. Now, I wanted to ask Dr. Raymond if he's still available. I know I'm sure he does intubations and all of that. From his experience, how comfortable are they understanding how to actually use a CPAP or a BiPAP machine, or even the ventilator, because it doesn't suffice putting the patient on the ventilator and just plugging in some numbers. You actually have to know what you're doing in order to help that patient. Otherwise, you can actually do more harm to the patient, because, like he rightly said, although we're talking about COVID now, but there'll come a time, and probably majority of the patients may be your non-COVID patients who need the vent, and you don't treat your status asthmaticus patient, your asthma, or the same necessarily as your, maybe they don't have COPD patients, a lot of COPD patients, but who knows, you may have them. People use firewood and all of that. You don't treat the same way as COPD. You don't treat them the same way as someone with CHF exacerbation. You don't treat. So you have to know how to use those machines, not just putting the patient on the vent, and not just having the CPAP and the BiPAP. So is he available? Can he maybe just enlighten us if they are comfortable even managing those? I know it's probably going to be part of the part of training, but it's probably good to also know if they, how comfortable they are with in those centers that have even those devices, how to use them.
Yeah, I would say honestly, I am very uncomfortable ventilating patients back home, especially in my center. It's more often the patients I would voluntarily accept to take and ventilate post-op, those who are post-op, who have been through long procedures, and I just need to, have them breathing spontaneously before putting them for extubating. But really having a patient coming with really hypoxia and all of that and managing them, it's very difficult. And even when we take the risk of ventilating patients for over 24, 48 hours, we often have to do a blood gas, which obviously means, collecting samples, having someone take the samples to the center where it's done, and obviously, transporting all of that. It's no longer efficient. It's no longer what it is. Or getting someone with a portable machine, and that involves now the family spending more on paying for the test, because at this point it's not the hospital's responsibility. It's now a different person bringing in the test to be done. So I'd say we feel really very uncomfortable, and that's one of the reasons why advocating for monitoring equipment, especially arterial blood gas, is very important. Also, I would use this opportunity to probably explain why training is very poor in these domains. I mean, you wouldn't expect medical students to be trained on an equipment that they've never seen before, which, I mean, it's one of the difficulties. You teach someone this is how to interpret a blood gas, but if they don't have the gas machine in front of them, if they don't have if they can't interpret and apply some of these measures, it's almost like a waste of that. So all of this, the training and all of that, will come when there is sufficient equipment, and it will be more practical to teach people with equipment at hand, rather than just telling them probably what a spaceship looks like when they're never going to enter one in their lives. So yeah, that's
okay. That brings me to my next question now. So because I know that, and this may be difference in training and terminologies. So when they use the word intensivist in Cameroon, which is what I understand you're intensivist, what is the scope of management? Because from what I know, intensivists generally, so from what you're saying, you do mostly like post-operative management when it comes to the vent. Because I had spoken with, I've collaborated with an intensivist in Bingo Baptiste, and he said he had trained in Israel for 1 year, and he was able to, talking to him, I kind of got the sense that he understood some of what he had intubated my uncle, put him on the vent, vent settings and all of that. And, he actually did a decent job. Okay. So, and you are in Yaoundé, which I'm saying, we'll consider that a tertiary center, regional hospital. So when your colleagues who are intensivists, is there anybody then? Do you use CPAPs? Do you use BPAPs? Is there anybody that uses the vent? And like, not just for post-operative, because post-operative is a different management. These patients are, depending if it's an elective surgery or not really a severe. But if you have your patient who comes in with with pneumonia and they develop ARDS, or they have hypoxic respiratory failure, status from status asthmaticus, from septic shock, from anything else, are your intensivists, when they say intensivists, besides even the vent, I mean, what's the scope? Is there any, so is this a general thing, or this is just maybe your own specialty that doesn't really deal with that?
Yeah, very, very important question, because I think one thing we should understand is that the scope of training, like, for example, I understand you're probably in the United States. The training there is anesthesiologists have a different training, and intensivists is separate. But in Cameroon, the training for anesthesiologists and the training for intensivists is the same, because we think that the basis is technically the same. Management of vital organ emergencies are the same. So it's the training that is incorporated in the training as an anesthetist. So yes, we do manage all emergencies involving vital organs, cardiovascular, respiratory, renal, and whatever emergencies the human body may have. And we work in close collaboration with the specialists from all the other domains. Currently in the country, there isn't any training that is specific to intensivists, which generally it's usually a 1 year or an 18-month course after you've had probably a training in another specialty to, get you involved in that. But we do have some persons who have had that training out of the country and who come back and whom we work with. But generally, the profession of an intensivist is appropriately by our anesthetist. In fact, the term in French is anesthésiste réanimateur, which is anesthetist intensivist.
Yeah. So I want to add there before it's just about culture, because the way Cameroon healthcare system is derived from the French culture, where in France, the intensivists actually are derived initially during the evolution of their medical school. Intensivists were anesthesists that were trained to be intensivists, which is a bit different from the way medicine is practiced in the US, where intensivists come from the internal medicine department. So that's really where the division comes in. So you still find that in France is still the same kind of practice, where the intensivists who do medical intensivists are those who do anesthesia and later on also subspecialize in different form of intensive medicine. Yeah, so that's the model Cameroon is using.
And which is fine. So from what I understand, then who manages your CPAPs? Who manages your BPAPs? Who manages your vents?
So those things, the CPAPs...
Are they pulmonologists? Are they exist?
Yeah, I think the CPAP, BPAPs are things that they're technologies that have been lacking, if I can say for Raymond. They're technologies that are available a bit in a lot of the intensive care units, but they have been overall vulgarization and use of that apart from the big hospitals. There were things
he is in a big hospital.
So there are things
in a big hospital, right?
Yes, there are things that I personally, when I was in med school, did not see much. And with COVID, they have come and they're available everywhere. As you saw in Bamenda, they had a CPAP machine and they did have a BiPAP machine, but people were not used to using them. So even respiratory therapists, what I wanted to add is that it's a profession that has been non-existent in Cameroon. Just because oxygen therapy, as Yauba is saying, it's now that is becoming the star in the show. So we're getting to using oxygen, and now we're getting to respirating patients more. Anesthesiologists were few in Cameroon, very few, very selected specialty with while we were in med school, we could not even enter your intensive care unit. I know that, Raymond, you know that very well. It was like a whole getting into, how do I put it, getting into the prim of things, which as students, you could not even see a patient who was intubated. That's how it was. That's how they made the whole thing look like. But right now, with COVID coming in and exposing the system, I think it's a call for action. And maybe respiratory therapists, Yvette's question was very pertinent, and Yauba really is something to take note of. Once you start oxygenating people, you will need specialists who are going to be able to take care of those vents other than doctors. Whom even in France, in America, they are being trained. There are technicians that know exactly how to deal with oxygen therapy. So I just wanted to throw the light that for my little knowledge I know about Cameroon, and I know here that there are very few respiratory therapists. I don't know of any.
Okay, thank you for that. Thank you for that. And that's more reason why Dr. Yauber actually, it just makes a more reason for training to use these devices to be part of a major part of this project. Because as you can see from what Dr. Raymond is saying, even though, they have good training in taking care of the severely ill patients, even some of the instruments that they need, because I'm saying this and people may not even, I'm saying this because we may not understand how much a CPAP or a BPAP or a high flow, a ventilator can make a difference. You can provide, once these patients are severely sick, you can provide them with pressor support, like, they're on drips or whatever, you can provide it. But if you cannot sustain their respiratory status, they won't make it. And so it's just something that maybe they need to make a case about this, getting respiratory therapies, and if they have to do training, incorporate people who actually can help really, understand when to use what settings for what management and some of that. And as I said, I am available if you need me. I can also chip my own little in. Thank you.
Thank you so much. Thank you so much, Dr. Brownheather. And we'll be getting the last question from Dr. Carlson. Carlson, before we end the program, your last question from you. Carlson?
Yes, good evening once more to you all. And thank you, Dr. Yalba, for the great presentation on this interesting topic. So basically, sorry, I was actually traveling. I was actually in the bus from one other city coming back to Jerusalem, from Tel Aviv, come back to Jerusalem when the presentation was going on. I might have missed certain points. I just wanted to find out from Dr. Yalba the timeline. It's a very nice presentation and a very nice topic which you have. But my greatest worry is the timeline for implementation. I know our country, Cameroon, we are very good in drawing up very nice projects which would exist on paper for about 10 years or 20 years. I don't know how long that is. And it's oxygen. As an anesthesiologist, I actually say oxygen doesn't give 10 years for a patient. The patient needs oxygen. It is now, and we don't have time to like spare for that. And the next thing is about acquisition and continuity in the maintenance of whatever thing we're to get, because my experience is having worked in the General Hospital. I saw the pipes. We had the pipes on the wall and the rest, which when a patient is crashing, what happens was we had to make calls to somebody who is downstairs in the equipment unit to carry a bottle and connect. You had a patient is crashing and he doesn't have 5 minutes. You have to make so many calls for a patient who is actually deteriorating. And as such, and if we have to bring the oxygen and there is no direct, like some direct management system in the hospital where there's some direct chain of command as to when to deliver oxygen to a patient and how to deliver the oxygen to a patient, it's still going to be as well as useless. The next thing is the training, the training aspect. I know Dr. Brownheather has spoken a lot on that, and also Dr. Raymond on training of physicians, which is physician and physician assistants, nurses, respiratory therapists. We can't belabel that aspect of it. And I just want to throw in my aspect and say I'm very ready to, if ever any training is needed to manage patients in terms of respiratory wise. That is my trade. For the management of COVID has actually made me learn quite a lot, as more in terms of different respiratory modes, which Dr. Brownheather was actually trying to bring up, because any patient with the different pathologies have different modes of management. Otherwise, you might have a ventilator and you actually use your ventilator to kill your patient, because your ventilator is going to give him a pneumothorax if you're not very certain on what different parameters to actually insert on your patient. Next thing is the economy. The last part of it is the economy of the usage of oxygen, if it's ever available. I thought this is because we have in my hospital we have an oxygen plant which produces oxygen continuously, so oxygen is never a problem for us. But the economy of the usage is the fact that at times, if I get now into the hospital, there are some operating rooms which have oxygen running at 15 liters, because the surgery the surgery finished last Thursday. We runs from Thursday from Sunday to Thursday here. There's some after surgery. There's some people who forget turning off the ventilator, switching off the ventilator. So there's a waste of oxygen which runs if you have to produce oxygen and you don't have somebody to monitor it, which like waste for that's over 48 hours now. That's quite a lot of oxygen, 15 liters per minute in about, let's say, 4 or 5 different rooms. That's quite a waste. So in our hospitals, we will be having some people to go around checking to make sure the bottle, if the cylinder is not in use, it is switched off. If maybe some other part, some other resource is not in use, it should be well managed. Otherwise, these resources which are scarce will still be wasted. Thanks.
Thank you so much, Carlson, for your questions, and thank you for always joining us from Israel. And it's a pleasure having you. We'll hand over to Dr. Yauba to answer your questions, and then we will take a round with all the co-moderators while we end the session for today. Over to you, Dr. Yauba.
Thank you, Dr. Carlson, for those questions. Let me attempt to answer them sequentially. One, the question on timelines for implementation. So this strategic plan has a time horizon of 5 years. So we have already started with implementation. I think as I said during the presentation, it's one of the rare strategic plans that I have developed, and that has one of the rare strategic plans that I've developed, and that we have started implementing before even it was adopted by the government. So we have already done a number of things, including mobilizing the necessary fundings and so on. So there are also a number of oxygen plants on their way to Cameroon, as well as cylinders. And then I think there are also some plant acquisitions, oxygen concentrators, additional cylinders, and also some consumables. So I think we are on good foot as far as implementation is concerned. So the only challenge that I see at this point is to what extent are we going to implement the plan during the 5-year period? And I think at the moment, the only limiting step will be that of funding. So if we are able to mobilize the funding, then I'm sure we should be able to fully implement the plan. But rest assured, this is a plan that is being driven by CHAI and perhaps UNICEF. So we will do everything possible to ensure that we do implement activities that are within our capacity. So the second question, on maintenance, I think that is a very important question. I think in the course of developing the different proposals, I've actually learned how to quantify the needs for piping within a facility. So I think the average cost for piping, for delivering oxygen to a bed, at least via pipes that are affixed to the wall, is about $1,800 US. And currently we have budgeted for about 1,200 beds, and these beds will be piped directly from the source and so on. And the challenge now is really to see how we repartition those beds. Where are those beds going to be? Are they going to be at Central Hospital, General Hospital, or regional hospitals? But I think we will discuss within the working group and see how we distribute that cost or that investment. Again, you mentioned another important point, and that of training and also the economy of usage, which I think is very important. We definitely need to take that on board, particularly as we gear towards piping hospitals. Yeah, because as you mentioned, if care is not taken, people may forget after using. They may forget to close the pipes after using them, and that also comes down to, or boils down to, a capacity issue. So I think these are some of the things that will be integrated in the training modules, and perhaps have hospitals set up some sort of check-in and controlling systems that will ensure that these things are effectively, or the pipes are effectively closed after usage. It's true, people may forget, but I think there is also the need of that system to ensure that everything is in order before people leave the theater or before people leave the different rooms where these pipes were opened. And the last thing, I think you had 3 questions which I have answered: training, timelines, and so on. So perhaps before I hand over the microphone to Elvis, I did discuss with the minister of Public Health about the possibility of him presenting his transformational plan to the diaspora, and he actually welcomed the idea. So I think it's left for me to go and tell him when he'll be presenting, find out his availability, and I think it is good. It may be a great opportunity, but one of the things that politicians really like is to see a large number of people. So I don't know, Mr. Dr. Former, what you do to get integrated into the health sector strategy, please, I think it will be helpful to figure out a channel that you can use to channel these recommendations to the Minister of Public Health. I think the good thing is that you already have someone like Professor Angwafo, who is a well-respected guy who takes part in this forum, so he can be a very good champion in transmitting those type of recommendations. I can also play my own role. So if there is any important thing that you think the MOH should be aware in terms of innovation, in terms of strategy, please don't hesitate to notify me. I will do my best to transmit that to the leadership of the MOH. Over.
Thank you very much, Dr. Yoba. It's really been a pleasure having you here today. And before we wrap up, I want to get back to Louisa to get some last words from you. Dr. Louisa?
Yes, Elvis. All right. Thank you so much, Dr. Yauba, for leading this conversation. And thank you to everyone for being so engaged. It's really motivating, and it gives us this positive energy to keep going when we have our own leaders, our own people come to us and let us know what strategies they have, and then see our own seniors, our own very own senior doctors showing that they are available to help. And I really want to thank you all, everyone who has said that they will be available to give any training, to help in any way. We are really grateful for that. And thank you once again, Dr. Muno, for this initiative for the town hall. Like every day you get to see the fruits of the town hall, including people learning about the health system, including people seeing where exactly they can chip in and help out in building a stronger health system. Thank you all so much. Thank you, Elvis. And it's always a pleasure being with you, Brian, and Christelle, and coordinating behind the scenes. Thank you, and have a great one.
Thank you, Louisa. And please don't go for too long. We missed you so much last time, and we are so happy to see you again here. Dr. Christelle, over to you. Is Christelle still with us? I'm sure Christelle left already. Brian, Dr. Brian.
Thanks again. Thanks, Elvis, and thanks, Dr. Yoba. Great presentation, excellent discussion, excellent conversation, excellent exchange. Really thrilled to have had this meeting today. Thanks, everyone. Over to you, Elvis.
Thank you. And our chair, Muno, some last words from you.
Yeah. I actually want to thank the whole town hall, everyone who shows up here every fortnight for us to talk about healthcare issues. I know a lot of you would want to do more. You want to be more practical. You want to change Cameroon in a day. But I have the philosophy that by talking about our problems, we start actually getting people to think about solving them. Really, everyone who shows up here all the time, I want to say a big thank you. The town hall belongs to you all. I've said this all the time. It's an initiative that Elvis and I started by just discussing, but it's sustainable. It's going on because of each and every healthcare professional and those who love healthcare by coming here. And I want to thank Yawuba especially. We've been trying to get Yawuba here for a long time because we know how important he is, not only in oxygen. Oxygen is a passion of his, but the Clinton Foundation in vaccinology, he has done a lot in Africa, and he has done a lot in non-communicable diseases, which cancer is one of my passions. He's working a lot in that. And I just want to thank him for going back home, for trying to lead the change by staying back home and trying to bring change. And right now, we're most likely going to get oxygen because of someone who is passionate about making sure that we do have oxygen in our hospitals. So we want to say a big thank you. And the platform is open to each and every member who has something that they want to present to the town hall. And I want to thank Dr. Yawuba for contacting the minister for us. And we are going to do our best to get as many people as possible. Sustaining this crowd, a friend once asked me, how do you get people here to stay here? Even the number that stays here, I'm even puzzled most of the time. But I think if the minister is coming and they know the minister is coming, I just don't know how we're going to control the crowd. That's going to be the problem. So it's going to be more of, so I think if the minister is accepting to come, we're going to welcome the minister, and we're going to be as civil as possible and as cordial as possible and try to understand the healthcare system of Cameroon. A lot of people in the diaspora really need to know how the healthcare system is so that they can be able to help. So a big thank you to you. A big thank you to everyone who is showing up day in, day night and night. And please, there are a lot of people here who are doing wonderful things back home in Cameroon and who are changing the healthcare system in Cameroon one day at a time. Please just contact us and let us know. We're going to provide you with a platform. Elvis, a big thank you to you and to all your co-moderators. Thank you, and thank you for your endless love towards the Cameroon Town Hall for Health Professionals.
Thank you so much, Dr. Mono. I can't say how much of effort you put to make this work. Each time we end the session, the task is for Mono again and I backstage with all the moderators trying to figure out who is going to be the next speaker and how it's going to be. And I think he's so passionate about this town hall that you cannot imagine how much time he puts in to make this work. We want to really thank you so much. And thank you again, Dr. Yawuba, for accepting our invitation. We know how busy you are, and to stay here with us for 2 hours has been really a big sacrifice. And just to recap some of the key issues we talked today with Dr. Yawuba, we understood that the COVID-19 situation has compounded the situation of oxygen in Cameroon, and you did a situation analysis to see how much of a problem it is in Cameroon. And you realize that we need so much to actually meet up with the oxygen needs in Cameroon, considering that just about less than 500 oxygen cylinders are available in the entire country, despite the need for more than 1 million cylinders. So we saw that information from you. You also made us to understand that very little suppliers of this molecule are available, and the time frame to supply it is also very long, considering about 3 weeks of time frame from the time you place an order to the time you get it supplied. You mentioned that because of this problem, the minister actually tried to put it as a priority in his planning and his project for revamping the healthcare sector in Cameroon by establishing a task force on the 11th of May to develop a 5-year strategic and sustainable plan to resolve this problem of oxygen in Cameroon, and to also help in sourcing out funding. And your situation analysis was done and provided a first-hand information as to what the situation is. And you mentioned some very interesting findings. You said there is no policy governing, the need or use of oxygen, medical oxygen in Cameroon, or the services, no norms or standards to regulate its importation, no budget line even in the ministry's budget for medical oxygen, even at the national level. and even no directive for financing. These were some of these issues you found out in your situation analysis. And you said it cost about $18 for a 24-hour delivery of medical oxygen in Cameroon. This is very expensive considering that our country is one of the countries that people live, more than 35% of the population live below the poverty line. So $18 is quite a lot for families to afford. If your patient has to stay in the hospital for 1 month, you can compound that figure and see what that means to a poor family. And you also said there's no medical equipment to diagnose hypoxia beyond district level. So this is a serious situation. You cannot treat what you cannot diagnose. You said 85% of reference hospitals do have access to at least one source of oxygen, but the percentage drops when you start going to the district level. And not all intensive care units or emergency rooms and operating rooms in Cameroon have medical oxygen. This is embarrassing because we all know the importance of oxygen in the operating room and in the emergency rooms. And the situation is even worse at the district level. And you mentioned something very intriguing. Just about 11% of hospitals, actually just 3 hospitals in terms of numbers, have oxygen plants. And some of these plants are not even functioning. And just about 15% of hospitals report data on management of hypoxia. And even among those 15 that report this data, the data is not standardized in such a way that can be extracted for policy. And he said decision makers do not routinely use data collected in our context in order to make decisions on oxygen supply in Cameroon. All these findings has been used to design a 5-year strategic plan, which you are championing. And your vision is to ensure zero hypoxia-related deaths in health facilities. Very ambitious, but you're optimistic. And that you hope to reduce 30% by 2025, all hypoxia-related mortality in Cameroon by equipping health centers and health facilities with oxygen equipment. This is a very serious project, and you have worked so hard to raise, to see that this is put in terms of the different aspect of what you are going to do: construction of oxygen plants, acquisition of oxygen cylinders, and training. And this comes up with a budget of about 114 billion francs CFA, of which you've already raised about 2% and have started implementing this project even before it was approved. This is really great. This is great work you are doing to the nation, and we want to thank you. We want to thank the Minister of Public Health for believing in his collaborators and for believing in the work you are doing to revamp this the healthcare sector by making sure that there is access to medical oxygen in Cameroon by 2025. We want to thank all those in the town hall who have actually promised to help you in this effort, precisely Dr. Brown-Hida and Dr. Raymond, who have already volunteered their services to you, especially in the domain of training. We do hope that this collaboration between those who are members of the town hall, healthcare professionals from Cameroon who are spread across the globe, many are going to watch this video after this. We do have a YouTube channel, we do have a website, and we do have a Facebook platform where we share this recorded version of the presentation. So you can be sure that even during the session, you might find just 40 actively viewing on the Zoom, but we always end up having more than 1,000 views after this session. So you can be sure that your presentation is going to have a very wide audience, and many more people will come up to volunteer their service to see how they can help. We also heard your plea to help for us to help source funding for this project, and it is still open to all those who can identify other actors who might be interested to fund this ambitious plan. So once again, Dr. Yaba, thank you very much for your time. Thank you for taking time to be with us, and we hope to see you more regularly at the Cameroon Town Hall for Healthcare Professionals. This is the only platform we can use to extend to